So hereby we've come to the final chapter where we want to show you really nice examples and also do some case discussion of IVL-assisted transfemoral TAVI cases. So of course, if we talk about transfemoral TAVI, I think it's important to emphasize that it's not a binary assessment when you look at the CT. It's not like either this is possible or it's impossible transfemorally. You have a whole spectrum of excesses you see of iliofemoral disease. So you have, I would call it the real cases which are impossible for transfemoral TAVI because there's just simply a complete occlusion, for example, or there's a stent which has just a luminal diameter of let's say 3-4 millimeters. So that these are total impossible cases to the completely eligible transfemoral cases. But in between, you have a whole zone from hostile environment to very challenging transfemoral access to challenging access. So this is a whole wide spectrum, and I would say IVL is really good for those cases, the challenging, very challenging cases, and in some cases where there's really no other alternative for these patients, you might even consider hostile environments, but I want to discuss this further in these upcoming case examples. So I said impossible transfemoral TAVI. I don't think I have to show you illustrations there. That's typically where the vessel is completely occluded, so there's no discussion. You cannot do this. But it's maybe interesting to show you some examples of what we perceive as hostile environment. So this is an example of a CT analysis of a hostile environment. As you can see immediately on the left top panel, you see an actual slice through this vasculature. And you see that this patient, he has, of course, iliac stents. So he has endovascular stents, both common iliacs on both sides. And this is not the only thing. He also has further on calcifications, quite a lot of small luminal diameters. And to me and to most operators doing TAVI, this would really be a hostile environment. You would do everything to avoid this access and look if there's maybe a good alternative access like a percutaneous transaxillary or a transcarotid or maybe even a transcaval access. But as you can see from this CT analysis, this is probably too tricky or too risky to go transfemorally. A second example of hostile environment, this is very nice as you can see. This is a combination of, on the left-hand side, you see, I talk of course for the patient on the right-hand side of the screen, but on the left-hand side for the patient there is a very long stent placement, and on the right-hand side there is a lot of calcification, but this is not the only problem for this patient. There's a combination of calcification and severe tortuosity. So also the combination of severe calcification plus severe tortuosity, this is to me a hostile environment where you really, really have to be careful what you're doing if you would proceed with this case transfemorally, and I would personally look most for an alternative non-transfemoral access. So I would say for these hostile environments, as we can repeat, for example, if there's prior endovascular stenting or there's a combination of calcification and severe tortuosity, you have to assess the risk of and the possibility of other alternative accesses like percutaneous transaxillary and transcarotid. But then, of course, we come to the very challenging transfemoral accesses, and I think IVL therapy or IVL treatment is perfect for these cases. We start with a very challenging transfemoral access. Here again, CT analysis. So we analyze the entire, first we start at the aortic level. This is the iliac bifurcation. You see a lot of calcification there. On the right-hand side, you see that the luminal diameter becomes extremely small. So probably too small to my understanding, but especially what is a problem here is also the access side, because you know you have to close this access at the end again. So if you have a calcification and a very small lumen just above your anticipated puncture site or access site, this is probably also not very favorable. So that's why we also analyze here the left side of this patient. You see 360-degree calcifications, luminal diameters which go really small, up to 4.5 millimeter. But further on in the external iliac looks okay. Also the access site, I I assess as being favorable for transfemoral TAVI. So with this case, we actually we proceeded and we planned this patient for IVL-assisted transfemoral TAVI. So again, as you see, I have a safety wire from the right leg crossing over to the left leg, and then we have this coronary wire, or 0.014 wire, where this is the IVL catheter with the shockwave balloon on top. So this is where we do the expansion. We inflate to 4 atmosphere. When the balloon is inflated to 4 atmosphere, we give our IVL therapy and our sonic pressure waves. Afterwards, in this particular case, because the reference vessel diameter of this patient was even larger than 7 mm, we even added a non-compliant 8 mm balloon to further expand this vessel and maximize the luminal gain. And then after that, we crossed with our transfemoral delivery system. We implanted our transfemoral, our transcatheter heart valve successfully. And then, of course, at the end, we also do always a control, angiographic control in these particular cases. You see, we had a very nice flow, no complications. Of course, we checked here at the access site, and of course, later on, we also checked on the common iliac part where we did the most of the IVL treatment. So this case was completely uneventfully performed and had a very good clinical outcome. A second example of a very challenging transfemoral access. Also here you can already immediately appreciate there's a lot of calcification. There's even some dissection in this right-hand side vessel. So probably this is a site which I would, if possible, try to avoid. You see these calcifications and dissections in the right common iliac, also in the external iliac further down. So this is probably an exercise which I would try to avoid. But of course, you also have the left-hand side. So now on this analysis, we also look on the left. There's also a lot of calcification, but okay, this is in a way ideal for IVL treatment. So this is 360-degree calcifications. This maybe less so. Here we have a 360-degree calcification, but still it's within our boundaries as we accept for transfemoral TAVI for IVL treatment. Here, a big chunk of calcification. So this is, of course, that's why I call it a very challenging transfemoral access. We have been thoroughly discussing this case. You know you might come in trouble here with your closure of your vessel. So this is not suitable for IVL treatment here because it's just a few millimeters above your puncture site. So this is not for IVL. So I'm concerned for my access site, but I'm not concerned about higher up for the common iliac. There I'm sure I will have a good result with my IVL treatment. But okay, with the necessary cautious and measurements and having a safety wire across this lesion, I will definitely proceed with this case transfemorally. So that's also what I want to show you here. So keep in mind the most severe calcifications were at the common iliac here. So again, we expand our shockwave balloon here, the 7 mm balloon. We expand to 4 atmosphere. We give the pulses. We treat this whole trajectory. Again, of course, especially in this case, I have a safety wire crossed over from the right to the left leg, and especially crossing over also the insertion place, because I anticipate maybe even I will have not a successful closure of my access site, but then I anticipate I can either use a balloon or a covered stent. But as said, again, for my IVL treated part, I'm not too concerned. I have a very nice expansion and treatment here with my IVL catheter. And then later on, also here, in order to maximize my luminal gain, I also went with a non-compliant balloon to further expand this vessel and get really the maximum luminal diameter in order to be able to pass with my TAVI valve. So these were two very challenging cases for even involving IVL assistance, but still now I want to give you some examples of two, as I would call it, challenging transfemoral cases, but of course with the use of IVL. But these are almost, I would say, now kind of routine cases which are acceptable and treated with IVL at our center. So here again, we start with our good pre-procedural CT analysis. You immediately see most of the calcium there at the common iliacs on both sides. We start first, as you can see, on the left leg. So I would say again 270 degrees calcifications here, luminal diameter here, circumferential 360 degrees calcification, luminal diameters of close to 3.4 millimeters, so rather small of course, but still it's not unacceptable, and the access site looks really good in this particular case. So we only have that problem mainly on the common iliac. So then we move to the right common iliac. You see on the left top corner again the axial analysis slice of this part. Here I would say probably the access site is also smaller and more diseased. So I think in this particular case we also went for transfemoral TAVI from the left side, of course with the additional use of IVL. And as you see, again, same setup, contralateral safety wire. We start with the IVL treatment with a 7 millimeter balloon. We don't only treat it here, the common iliac, but also lower down. You have the luxury of having this balloon which has 300 pulses, so you can just maximize the use of this balloon by treating the entire almost iliofemoral axis, and that's also what I do to get the maximal out of this treatment and to have the maximal compliance of your vessel when having to cross. So here this is even all the way up to the common femoral artery. And then we brought our transcatheter heart valve successfully up. We did a very good implantation here, as you can see. And then afterwards, we have a check, which you can immediately do from the contralateral side. We have a check, as always, angiographically. So you see very nice flow, no rupture, no bleeding, even no obvious overt dissections. Of course, very often you see some small localized, very tiny site dissections which heal completely spontaneously, so they do not need any additional treatment. So this is a perfect and very classical result, I would say, at the end of a routine IVL-assisted transfemoral TAVI case. As a second example here, just to show you how we do the assessment pre-procedure, again you see a lot of calcification all over the way from iliac bifurcation to femoral bifurcation. Of course, on the left-hand side, you see immediately there's more tortuosity involved. So as I told you earlier, combination of tortuosity and calcium is not something we do like. So just having that additional tortuosity on the left-hand side or the left side of the patient will probably push us to do the case from the right side, from the right femoral and iliofemoral axis. So we still do a screening, of course, of this entire vessel, but due to the tortuosity, it's not, as you can see here very nicely, tortuosity on the left-hand side. So then it's more important to go to a detailed analysis of the right side. So you see severely calcified, also 360-degree calcified, but luminal diameters which stay above 4 millimeters. So we assess this as almost routine IVL, a good case for IVL-assisted transfemoral TAVI. The access site, of course, is also an additional concern, but still there's calcium, but mostly posterior. So we think this is, won't probably give us too much problem to close this vessel at the end. So then here the case, you see again here, safety wire again, as we like in these cases, shockwave balloon inflation. Also here we give the sonic pressure wave and we increase the compliance of this vessel. Then an even larger balloon based on the reference vessel diameter to get further expansion of this balloon with a non-compliant balloon. And then we delivered this, here we had an evolute valve in a bicuspid patient, very nice results. And then at the end, we had a very good closure as well. As you can see here, this is, as you can see on the closure device, this was a collagen-based closure of the vessel. But again, nice flow, TB3 flow, no obstruction, no bleeding, no stenosis. Okay, so then we come to the summary in which I give you an overview of our outcomes in these 44 patients treated over the past 30 months. So in none of these patients, so 0 of the patients, there were major vascular complications observed. Only in one case, there was a spiral dissection of the external iliac artery, but this was easily resolved by use of a bare stent. So, in total, I would say, to summarize, we offer our patients a fully percutaneous TAVI program. As in most centers throughout the world, 90% of cases can be treated by the routine transfemoral TAVI approach. Thanks to the use of IVL, or shockwave treatment, we can push this transfemoral approach to 95% of our patients. The remaining 5% of patients, they are also preferentially treated in our center percutaneously, either transaxillary or transcaval approach. So this is offering our patients a truly safe and effective therapy and TAVI program in our center. I hope you found this tutorial very educational and that these insights can help you in expanding your transfemoral TAVI program at your center and being able to offer the best possible treatment to your patients.